Hmm.
And this is a recent one.
Yeah.
Child PUA, no significant cirrhosis, biopsy-proven HCC. He's got multifocal tumors. He's got a pretty good distribution of tumor throughout his liver. All right. At your institution, how would you tackle this case? I'll tell you what we did, and it was not exactly the way that you would have thought it would have gone. And so how would you have tackled this?
So in our place, then the first discussion comes whether they get liver-directed therapy or a clinical trial or systemic therapy. In all likelihood, being at an academic institution, there's a strong likelihood this patient would get a clinical trial. But let's say clinical trial is not available and they're getting liver-directed therapy for the sake of discussion. We would probably start with the radioembolization. And by meaning start with the radioembolization, you do the mapping. And then you make the decision after the mapping, right? So I don't make a decision as to how I'm going to treat until we do a mapping angiogram and see which out of these that we can select and isolate, similar to what Kramer was referring to 5 minutes ago about trying to isolate tumors, even if you have to do it sequentially. Because that's been our approach as well, instead of just doing a shotgun whole liver approach here, which I don't think is probably the best idea.
Sid, what about systemic for this patient? Is that something you would consider at your institution?
So let's say they weren't on a clinical trial and we decide to do liver-directed therapy. I think there's two scenarios. You either do liver-directed therapy and then you combine it with systemic right away, or you do the liver-directed therapy and then you assess for the response, and then you might decide to do systemic therapy later if you want to.